some of the overlaps between testing in the non-human animal and the human animal that I hope to kind of discuss is what tools are available on both sides. What is the process to get a test done in the veterinary clinic versus the medical clinic? Is there more availability of one kind of data or another? And is innovation more supported in one platform or another? So Elizabeth, I wanted to let you kick off the testing.
Yeah, so I have let me share my screen. Yeah, I found I was looking at this Mayo Clinic algorithm for testing. Okay, what bothers me here, one of the things saying is specified the Ehrlichia, Lyme disease, so forth are included in the northeastern and upper Midwest of the United States. Okay, so in other words, so the flow chart, if you keep the patient are other than from the Northeast or Midwestern, perhaps they're not suspicious for Lyme disease. So this is in my study I published. You can see in 2010, yeah, perhaps that was true in the Northeast, upper Midwest, was a lot of positivities. But in 2016, the data have shown it's across all 50 states. So you can't just say in contemporary, like this Mayo Clinic algorithm, this is actually published in May or June May 2022, okay? And that's a problem when the clinician, they are trying to follow this algorithm, you know, they can miss out a lot of patients, right? And I also want to look at the animal testing. This is from the IDEX lab. Okay, there are strategies in successful Lyme disease management. They're saying to screen and quantify, recheck, retest. Okay, so in fact, they said every dog every year need to be screened for Lyme disease. So if you look at their floating chart here, you have a positive test result indicate, all right, they're using C6 antibody with the Lyme quant C6. So I think quant means you give a reading. You don't just give a positive negative, right? And keep following, and then you treat it, all right? And then with the DOC, and then you monitor, and then you retest the antibody level to confirm the success of a treatment. So you have something to go by, right? Supposedly you can measuring the antibody rise and fall to see the progression of the recovery. So one of the things with the human is you give you a course of antibiotic and then you're cured. So there's nobody really this is what I propose. You really need to have a quantified way to monitor the therapeutic monitoring to see how successful the treatment is. This is like the thing when people are in complete treatment, all right? Or you say you like to be chronic. You're not treated to completely killed in the first round. So this is why I found that the animals, doctors or animal research are doing much better work than the human ones. I don't know what does the Dr. Brightworth, do you have something to add on to this? Your thoughts on comparative zoology here?
Yeah, thanks, Liz. I think, again, tick-borne diseases in particular, if the first tick-borne disease that was ever discovered was discovered by veterinarians in Texas because cattle having Babesia bovis. And that was, back in the late 1800s. I think because there's, again, animals having so many ticks, whether it's a cow or a dog, and occasionally the cats as well, there's been a lot of emphasis on tick and other vector-borne diseases in veterinary medicine. And IDEXX in particular, and I have to disclose the fact that I have been a consultant for IDEXX for many years and remain so in the area of their test and their approach to diagnosis of tick-borne disease. And as is true in human medicine, there's not uniform agreement amongst all veterinarians, but the vast majority of veterinarians in the United States actually use the IDEXX 40X test, which screens for Lyme disease, as you pointed out, ehrlichiosis, which is a chronic disease in dogs, anaplasmosis, which we have two anaplasmas that are important, one of which is chronic, one of which appears to be acute and either self-limiting or rapidly responsive, and then for heartworm disease. So we do screen, and we do recommend screening annually for organisms that can cause chronic infection. And one, it's provided the profession tremendous epidemiologic data. So anybody that's viewing the seminar can go to the CAPC website. It's the Companion Animal Parasite Council. And I think the maps there for these specific vector-borne infectious agents are extremely comprehensive, because it represents millions and millions of data points that are generated each year by veterinarians. And that information is, whether it's whichever company is doing it, is sent to our professional parasite group, and they put it out in their maps.
Oh, that's amazing. I really would like to get a hold of that one, because that's one of the thoughts we have. Say, how can we correlate with veterinarians' data to see is it endemic, pandemic, wherever the region that the humans should be aware, right? So there's kind of a data already there, like public health wise, and people should, humans should pay more attention. The infectious rate, the disease, right?
Absolutely.
Yeah. The thing is, with human testing, as I was saying, the test was developed, I don't know, in the 80s, 90s, and then they're only trying to make a better mousetrap. It was basically the foundation of the serology testing have not changed. They're just, try to, from a sonicate to recombinant ones, and it is not much of a new invention. So my thinking is, with all this new molecular-based testing, we could literally detect a cancer cell in a drop of blood. Why couldn't we try to improve the Lyme disease testing with the newer technology, neuroscience? And the IDEXX one is extremely convenient, and it's a point care. In fact, I know that who orders this test to test on themselves for Lyme disease or whatnot, right? Have you heard that one?
Well, when IDEXX developed this particular test, most serology tests use a species-specific conjugate. So if you're testing dogs, you have to use a conjugate that is against dog antibodies and cats and what have you. But this test is not species specific, and in regard to the C6 peptide, should give accurate results for other species. IDEXX doesn't mention that. They don't advertise that because it would be inappropriate, or they certainly don't even condone it. But what you're saying is, in reality, true. We use it in testing horses, and it's not approved for testing horses. But it will work. It'll pick up the C6 peptide. And, we started using the C6 peptide and the IDEXX test probably back in the mid-90s. And what I can say to the physicians, at least if you're testing dogs, the specificity of that peptide is amazing, because we've tested thousands of dogs from areas that are not endemic for Lyme disease, and have either never gotten a positive, or if we did get a positive and I contacted the owner of that dog, they had a travel history to a Lyme endemic area. And probably the strongest data is when we test dogs from Brazil and Argentina with our collaborators. It's almost never that we'll get a positive on that particular test from those areas. So yeah, for me as a clinician and with a strong interest in infectious disease, sensitivity is important, but specificity is a beautiful thing if it's that good.
So they don't have a second tier confirmatory. No, it's just one test.
Absolutely.
Yeah, okay. It's a quantitative, right?
The screening test, the SNAP test, where it's done at the bedside, essentially in the veterinary hospital, takes about 20 minutes from the time the either whole blood or serum's applied until it either shows a blue dot indicating that there is an antibody to that particular organism, be it Lyme or Ehrlichia anaplasma. The heartworm tests in the United States have been developed over decades, and because heartworm is such a serious disease in dogs, any new test has to achieve at least a 98% sensitivity for testing. And I guess the one advantage that, when we talk about pros and cons of diagnostics in veterinary medicine and diagnostics in human medicine, although we really do not like to do it, one advantage we have in veterinary medicine is I can infect dogs with Ehrlichia. I can infect dogs with Anaplasma phagocytophilum, and I can look at the antibody kinetics over time in those dogs, and to your point, determine if quantitation of those antibodies prior to and after treatment are beneficial in the clinical setting. And then you can actually take the test and use it in the clinical setting and generate additional data, which IDEXX has done for the Quant C6.
Interesting.
I mean, that's amazing. I need to talk to you afterward because I know people have tried to do it in human in the laboratory. The curve, you have to set up a standard curve, right? Because how you compare the progression of your new sample versus your old sample, right? And what kind of curve do they use as a standard? That's
when I think one of the challenges, at least in Lyme, is that it's a apparent tissue-based disease. It's a stealth pathogen that, in a sense, comes and goes. And maybe we have to look at downstream products, proteins fostered. I'm curious from Elizabeth, I wonder if you can stop screen sharing now.
Yeah,
that's okay. And Charlotte and Steve, if you're in the office, what is the importance of testing for you? And what's the availability? It sounds like the dog has at least a Lyme by the bedside.
Yeah.
Drop of blood.
I think that, listen, it's great that they have these bedside techniques for animals. For humans, we are, I don't want to be a dissenting voice about how far lab testing has come for these vector-borne infections, but I think it's a very big disappointment, serological testing for Lyme. I mean, if you go by CDC criteria, CDC admits that it fails to capture 90% of cases. The C6 is exceedingly specific, but a lot of patients with Lyme are not C6 positive. And it's like the uncle who never shows up for the disappointing uncle who never sends a Christmas gift. I mean, it's like these lab tests are they fail sometimes more often than they succeed in diagnosing patients with illness. So I use multiple things. Like in my office, we use CD57 testing in addition to Lyme testing. People should know that some bands, some numbers on the Lyme Western blot are so specific that really if people have these numbers, these bands like band 31 or band 23, they're greater than 99% specific for acquisition of Lyme, of Lyme bacteria. So people should know what the antibodies mean and what the bands on the numbers on these Western blots actually mean. And I think the greatest need, though, is not just for initial diagnosis, because if people said, okay, well, if the tests are quite poor in sensitivity and the suspicion is high and the treatment is relatively innocuous, we'll give some month of antibiotics or what have you and see what happens, that's fine. What do you do then? Because you can have people with very high positive ELISAs and 10 bands on the Western blot who are then treated, and then when they relapse, then the doctors start fighting. And we don't have good direct detection tests for Lyme or Bartonella. We have the triple draw at at Galaxy, but it's it's not none of these tests are perfect, and direct detection tests is something that are desperately needed. I know that there was a specific immune complex, Bibidofra immune complex detection test that was being tried to be developed about 10 years ago, and that never made it through, and that one had a lot of promise. There was a culture from Bibidofra that was closed down. They shut that down by not sure exact reasons why that was stopped, but that's what's needed. I mean, serologies are one thing, but like, for example, there's a study of Lyme patients where they all had erythema migrans to get in the study, and then the people who ended up doing fine and not developing chronic illness, they had very positive antibodies, and the people who were chronically ill after documented erythema migrans, they had negative antibodies. So there is this weird opposite effect where people a lot of times will be serologically negative and be more severely ill with Lyme. And they've also shown in other studies that samples of blood that are seronegative tend to be more commonly PCR positive for Bibidofra and vice versa. So it implies that seronegative is associated with a higher infectious disease burden for Lyme. So we have like lots and lots of problems. The observation of blossoming out of a test has been published now with Lyme, where somebody was treated because of clinical suspicion, was antibody negative. And then I always say it's like the bacteria bind to the antibodies. And if you kill some bacteria, free up the antibodies, it's like you're unzipping the zipper. And now, more antibodies that get picked up on the test. So that's been published with Lyme too. It's something I've observed personally, not just for Lyme, but for Bartonella and Babesia as well, that the test turned positive after treatment, the serologies. So I just think there's so many inadequacies across so many domains of serologic testing that they're so unreliable that they're helpful for initial diagnosis. And then after that, it's very, very difficult to make heads or tails because there's so many published studies of people where they've been culture positive for Bibidofra, where they were serologically positive initially and then went negative and then were never positive again. And meanwhile, they were Bibidofra culture positive. So that's my 2 cents.
Yeah, I certainly agree with Steve, both on the veterinary side and the human side, that serology is just so complicated and its interpretation is so complicated, and ultimately it can be used to support a diagnosis, but it really only means that there's been exposure to an organism and doesn't actually confirm that that organism's there. And that's where, as Steve said, direct detection is of critical importance. And we are very fortunate as a result of a grant from the Cohen Foundation to have been working on droplet digital PCR now for the last 2 years for Bartonella, Babesia, and Borrelia. And I don't think it will surprise Dr. Mayo or Dr. Phillips, who are seeing patients all the time, or Chris, but you guys are right, you have been right, and we will be able to provide the data to support the fact that many of these people at least have DNA of all 3 organisms, 2 out of the 3 organisms, or any combinations of those 3 organisms in their blood.
In their blood. Oh.
We've got a lot of work to do, but and I usually don't discuss unpublished data, but I think this data is important enough. And I think, what we learned diagnostically with COVID has moved molecular diagnostics forward at a pace, kind of like the space program, if you will. I think we're going to make a lot more progress in that area in the next few years than we have in the previous 20 or 30. But I can tell you that what we are currently finding in our laboratory, which we are going to publish obviously as quickly as we can and as soon as we're absolutely confident about all aspects of the data we're generating. But I think why these cases are so complicated and why they're so difficult to treat is we should not just focus on Borrelia or Babesia or Bartonella. We really need direct detection to say which combination our patients have.
Do you use a gene? Is that the gene sequence and then you directly detect the gene?
Yes,
Okay.
Elizabeth. And what the difference between qPCR and droplet digital PCR is droplet digital PCR is essentially somewhere around 2,000 individual PCR reactions versus qPCR starting with a single PCR reaction and then amplifying, amplifying, and amplifying. There's certainly similarities between the two techniques, but there's droplet digital PCR, which was kind of the first to be used in infectious disease diagnosis. It's been used for cancer diagnosis for years. And now digital PCR, which eliminates some of the challenges associated with droplet digital PCR, is being refined and will also help us move this forward. So I'm very optimistic that we're going to be able to give better direct detection results to veterinarians and physicians in the future.